And it looks like we are building a critical mass of attendees, so I think we can go ahead probably and get underway. Again, this is the Public Health Practice-Based Research Network's monthly virtual meeting. I'm your tour director today, Anna Hoover with the National Coordinating Center, and we are very excited to have a presentation of work being done by our North Carolina Public Health Practice-Based Research Network. Dr. Michelle Issel, who also happens to be the chair of the Keeneland Conference Planning Committee, and we'll be talking a little bit about the Keeneland Conference Scientific Advisory Committee and the Keeneland Conference in general at the end of today's call. But Dr. Michelle Issel is going to be sharing with us some of the North Carolina PBRN's work that's very important these days, a topic that keeps coming up, resilience in local health departments, particularly around maternal, child, and adolescent health programs and services. So with no further ado, I would like to turn things over to Dr. Issel.
Well, thank you, welcome, and thank you. So I am the slide mover, which is always a fun role to be in. So a little bit of a disclaimer as we get started. I've only been in North Carolina since the beginning of July, and I moved my grant to North Carolina, but I started all of this work while I was still in at the University of Illinois in Chicago. The grant that I'm going to be talking about was funded through the Robert Wood Johnson Foundation under their PHSSR portfolio. And as you can see from this slide, we had plenty of collaborators and minds put forward in both the proposal and the ongoing work. My colleague Arden Handler is at University of Illinois in Chicago, as is Allison Holbrook. And then Laura Siebold and Carolyn Leap, many of you may know, are both at NACCHO, and NACCHO's been a really major partner in this project. And we've had several RAs and help us along the ways. And through NACCHO, we also involve City Match and AMCHIP, particularly in the development of the questionnaire. So I just want to make those acknowledgments up front to get us started. This slide says current climate, but we wrote the proposal in early 2011, late 2010, when we were still pretty much in the recession, with a lot of concerns around fiscal and decreases, budget cuts. This was at a time when we started this project and the proposal when things looked really grim in public health. Not that they've gotten a lot better, but to some extent they have. And in particular, at the same time that we had these economic issues going on, there was also this big push occurring to have more of a life course perspective to the public health programming and to really focus on population public health. So there were some societal trends happening. And of course, this was also the same period that the Affordable Care Act was passed and began to be rolled out. So a lot happening. And we wanted to try and figure out if there was a way to identify in local health departments what were some of the best practices for, particularly for maternal and child and adolescent health, MCAH, although I'm going to say MCH because sort of my default language, and try and identify if there were some health departments that seem to be doing what we might think of as best practices in terms of their own resilience during these really turbulent times. And so we focused on essentially the services or programs that they were delivering, some of the economic approaches or strategies, and then the delivery or performance of the essential public health services. And I'll talk more in depth about each of those in just a moment. And then through our collaborations with NACCHO, they wanted to add this concept of collaboration, so that got woven into our survey. And because of the timing of the survey, we added some items about the Affordable Care Act. I'm not going to talk about these last two today. So we developed the survey really with a lot of input from the Maternal and Child and Adolescent Health Advisory Group at NACCHO. They really helped fine-tune the wording. We developed a list of 35 programs/services specific to the maternal and child health population. And we drew that from the list from ASTO, from existing NACCHO surveys, and our own brainstorming around, with colleagues. And we did some iterative pilot testing to refine the wording and the questionnaire overall. And then we actually launched it. I can't believe when I looked at this slide, it's been 2 years now. We sent out the survey using Qualtrics with the help of NACCHO. They helped us select a random sample of their members, and it was stratified by LHD size so that we would really try to oversample the large LHDs. And our respondents really were, we asked people who were responsible for administering and overseeing the MCH programs, and so we would try and get the most accurate from within the organization information on all of that. And we've been using Stata for our data analyses. This slide shows our response rates, and as you can see, it did vary by size of LHD, and the overall response rate of 49%, NACCHO would say that that would be probably on the low side of their normal, but not of concern from the point of view of NACCHO's typical response rates, which was reassuring to hear from them. I'm going to do my strengths and weaknesses up front in the presentation rather than caveats at the end. So we really did get a nice nationally representative sample of local health departments. And I think the fact that we were able to get input early in the questionnaire development really helped us strengthen the face validity of many of our questions. Of course, we have limitations. No, it's hard to be a perfect study. Really one-time cross-sectional survey, and it's self-reported by the health departments. We don't have any way to sort of do self-report reliability checks on any of this. The response rate, 49%, while it's acceptable, naturally we'd all love much better. And we did have a little difference in that response rate by jurisdiction size. And it's now been 2 years ago. So put yourself, when you see these results, thinking 2 years ago what local health departments might have said. And I'm going to just really sort of whiz through some of the key findings from that survey so that we'll have plenty of time to talk at the end. The first part of our study was focused on the programs and services for maternal and child health. There had never been any, I'll say, systematic survey to understand exactly what local health departments were providing for maternal and child health. And so we asked each of the participants for each of the 35 services or programs whether or not their health department provided it or contracted it out. If some other agency in the jurisdiction did that, if they thought it wasn't available or they didn't know. Here's the sort of major summary of those findings by jurisdiction size. You can see these by most frequently provided, meaning the highest percent of health departments. So for medium and small-sized health departments, a very large proportion provided childhood immunizations. WIC was really right up there in terms of percent of health departments that provide WIC. Breastfeeding shows up across all three sizes in this sort of top 5 services provided. But you'll notice that for the large health departments, HIV and STI testing shows up in contrast to the small health department that does prenatal testing. So there are some differences here by jurisdiction size in terms of what's provided. On average, small health departments provided the least number of services, with medium-sized health departments on average providing the most of services, and the large sort of in between. So you can see that while the numbers don't, they sort of hover around the 13 out of the 35 services, there is some actual significant difference between them in terms of the number of services provided. This slide sort of reiterates that. On average, health departments provided 13 of the 35 MCH services. Bullet number 2, I want to draw your attention to in terms of what services are not being provided at all by 10 to 15% of the health departments in our sample. They did not provide prenatal care, prenatal home visits, pediatric dental care, nutrition services, nor school-based clinics. So those were really very maybe want to think about some of that. And then bullet number 3 says that even fewer health departments provided school clinics and pediatric dental care. Those were really the least available across all of our respondents. This graph, a little bit busy, but summarizes what I've just been talking about in terms of the bottom dark blue, the percent of health departments that they provide or contract out. And you can see that as we move to the right, the percent of health departments providing those services listed across the bottom decreases, so that virtually no health departments are providing foster care, mental health, primary health care for children. Very rare. But as you can see, WIC, immunization, breastfeeding, lead prevention is being provided by nearly 70 to 80% of health departments. In summary, there's a difference by health department in terms of what services they are providing. Again, childhood immunizations, WIC, breastfeeding support, lead poisoning seem to be provided almost regardless of size. And other agencies are providing some of these services within the jurisdiction. With regards to the performance of the essential public health services, we wanted to know, particularly with regard to the maternal and child health population, not the performance of the essential services generically for the health department. So how would each of the respondents rate their performance on doing these for the MCH population? So for each of the 10 essential services, we had a set of items. We have good alpha reliability for each of those 10 set of items. Quick finding here is that competent workforce assuring access and informing the public received the highest scores. And I want to go back here for just a second. Yeah, I'll go forward. With enforcement being the lowest of the domains being scored by health departments. And that, in a lot of ways, makes sense because there's not much enforcement with regards to maternal and child health, um, unlike sanitation and inspections and that sort of thing. There was a little bit of difference by size and the essential services scores, such that most of those differences were for the small health departments, mixed for the medium, and not significant, and interesting, a little bit reversed for the large. And this is better shown on my next slide. Just a table that shows, again, the blue being small, yellow medium, sort of the pink columns for the large jurisdictions, and really showing the correlation between size and that score for each of those essential services. We do think that there's something here to be looked at in terms of the way in which that becomes, those relationships start to reverse for the large health departments. Not something we would have expected, something that I would say we're still scratching our heads over a little, but something to really think about, and how for the medium-sized health departments, the relationship between their size and performance is a little bit more variable. Overall, the number of services and programs of the number of those 35 was related to the score, and that was a significant relationship. Within the population size, the number of services and the essential public health services score, that within wasn't significant, and I don't have any graphs to show this. And then for the large health departments, that relationship between the number of services and the performance was reversed. And even though it wasn't significant, again, something going on with the large health departments here. And our third major objective had to do with the economic strategies. So what were the health departments doing in terms of efforts to address any kind of economic hardship that they might have been experiencing, and again, in particular in relationship to what we on the grant team say preserving our MCH services. As far as I know, this is the first time where anyone's trying to look at actual true strategies as opposed to the cost or amount spent. So we identified 7 different possible economic strategies that a health department might take, and you'll see these in a moment on the next slide. Here I want to really point out that the scoring here, a score of 1 means that they took no steps to do that strategy. 2 was a few, 3 a moderate number of steps, and 4 would be a lot of steps to enact that strategy. And I'm not going to report on, but we asked whether or not there was motivation to preserve those MCH services and whether or not there was an effect. I'll just parenthetically say that the ends on these 2 questions dropped off dramatically, so they're not as useful as we might have hoped, the way life happens. So here were the 7 strategies that we included on the survey. The tallest 3 bars are green for decreasing expenses, blue increased revenues, and sort of the rust to increase capacity. And you'll know that those scores average around 2.5 or so meaning that the health departments on average took somewhere between a few and moderate steps, going back to our 2.4, 2.5 would be around between few and moderate. So we didn't ask how many. That might have been a little bit tricky. The one thing that I do also want to point out on this slide was the gray bar is really small, and that was eliminating services. So that overall, on the average, there were very few steps taken to actually eliminate maternal and child health services. So that's sort of the picture of what the health departments were trying to do in terms of responding to budget changes. And our fourth objective was really to take all of the preceding information, in a sense, and develop some sort of a profile that captures what economic strategies were most effective, where do we have the highest level of performance of the essential public health services, and can we sort of combine that with a profile of which services are being provided. And the answer to this question is analysis is pending. I'll be presenting on our cluster analysis at Keeneland in a couple of weeks. And we can talk, I think, a lot more about how does one create these profiles beyond the simple jurisdiction size. And I'd be happy to talk about the cluster analyses we've done so far. We do have service clusters and strategies clusters, but I'm, for today, not prepared to go into those details. So in thinking about who might be on this call, I thought it would probably be useful to talk a little bit about more generically some of the research implications and caveats that we were experiencing. So, of course, this whole notion of how to increase the response rates when you're asking organizational data, and I think NACCHO has some great techniques. We did the usual follow-up emails, try to provide some incentives, but I think that this is going to be a perpetual problem for us, particularly when we have a defined N, actually sort of a population of organizations. Those response rates really become even more critical. The whole issue of data management, going from Qualtrics to Stata, thinking about merging data, passing it back and forth between NACCHO and us in terms of managing data in ways that don't violate our IRB agreements in terms of confidentiality. Those kinds of issues took a fair amount of thinking through and dialogue and being careful around. We're in the process right now of linking our survey, and we have 3 waves of the NACCHO profile data, and linking that all with the FIPS codes. And the amount of work that takes, well, we'll have a nice longitudinal data set in the end. I don't think any of us can ever anticipate fully what that means, and even when we get the data linked, as hard as NACCHO had tried, for example, and just not to point fingers, but use an example, we tried to have our 35 services match various data sets, but the profiles didn't always ask it exactly the same way. So then as soon as you start doing any of this data linkage, the possible set of variables to use across time starts to diminish pretty interestingly. And then I just wanted to acknowledge that when you have partnerships, there are compromises that get made. Some feel more comfortable than other compromises. That's kind of the nature of the game. We added a couple of additional sections to this survey, but it was also wonderful to have a different voice and a different perspective on the team. So, and figuring out what are the optimal partnerships, I'm sure that that's on every researcher's mind as we move forward in these complicated questions we do. And then I gave some thought to more specifically for us as PHSSR scholars, I'll say, some of the issues that I think more at a discipline level arose for me as out of this project. This whole question of how do you characterize organizations beyond the small, medium, and large, which has been our typical way, or the governance structure in terms of they're autonomous or state or mixed. We need to really begin to think about much more nuanced ways of categorizing ways in which local health departments are functioning and providing services. I see this as an interesting and potential challenge. The other thing that I'm going to acknowledge our study does not even pretend to try to do, which is to connect these processes, these economic strategies, or the delivery of services as organizational processes with outcomes. And if I were asked to, how would I do that? That would be a real interesting challenge to try and identify which of these processes are strong enough and which outcomes would be sense enough to be able to see a potential connection and link correlation. So this B is another challenge for us in the field, I think. And the third is sort of one of my soapboxes, and I have no clue what the 21st century equivalent to a soapbox is. I'm open to suggestions on that. That Arden Handler and I always had this interesting back and forth debate. We have no theory to guide what should be the dependent and what should be the independent variable. So does performance of the essential services lead to more or different services, or is it that we have constellation of services and that influences our performance of the essential services? And we had interesting and fun back and forth about that, but until we have some theories that ought to guide us in terms of more of a cause-effect relationship, we're stuck at sort of this descriptive, here's a relationship, we don't know what direction it goes, and we don't have the longitudinal data to help us derive theory. So I see this as sort of a broader set of issues for the discipline of public health systems research. And then I just wanted to share that if the slides get shared, this is a list of where we've disseminated thus far. And we did 2 webinars, and we've got one NATO brief report that's already out, and a second one that should be coming out hopefully by the end of this month. And then we've done several presentations. So some of these findings are out and about. I want to make that clear. And I'm finished with my presentation, and I believe we had scheduled a little time for questions. And
absolutely. Thank you so much, Michelle. That was a great great presentation with a lot to chew on, and I'm sure there's a lot of room for discussion, particularly on some of those latter points that you threw out. I'd like to open the floor or the phone line for any questions folks have. Um, for anyone on the phone and not on the computer, Scott Frank from the Ohio PBRN recommended we use the word blog box instead of soapbox.
I like that. Great. Good. Thanks, Scott.
So we'll make sure to trademark that and put Scott's name on a citation every time any of us uses it.
Okay.
Thank you, Anna. This is Scott Frank. I just wanted to make a comment on your large health department findings. These are not inconsistent with some of the work that's already been done, that it may be more about right-sizing health departments rather than continually increasing size of health departments. Some of Glenn's work demonstrates that, and we're in the midst of our analysis of our study, and it very strongly shows the same thing, that the medium-sized health departments appear to have the best performance, if you will. So your finding is not unusual.
Oh, good. Thanks.
And we have a question from Catherine here, who would like to know if the data is available by state.
No. I don't anticipate us doing any analysis by state. If you think about our sample size is 240 and the ways in which we did systematic, stratified, random sampling, I would worry about the ends per state not allowing us to do some statistics. So, I mean, if we planned to do it by state, probably our sampling methodology would have been different.
All right, and it looks like Catherine's typing a follow-up, and she says it makes sense.
Right.
Are there some other questions for Michelle? While we wait, I had a question regarding your third objective and the instrument itself. I was wondering how you operationalized externally consolidate for your interview participants, or for your survey participants. I thought you had the divisions there, internally consolidate among the options, and you had externally consolidate. And I was just wondering what that looked like in terms of the instrument they were completing.
That's a great question, and I'm quickly going to my code book so that I can give you a precise answer. Because we did try to, for each of these strategies, we tried to sort of give examples so that it would be. So when we talked about internally consolidate service, for example, combined immunization and WIC clinics was our example. For externally consolidate, we said, for example, regionalization, share program staff with local providers as a way to sort of give them a cue as to what that might look like.
Excellent. Well, what I was thinking about actually toward the end, and again, I think there's a lot to chew on in those last couple of slides, particularly when you were calling out the need for more nuanced ways of looking at local health departments with all of the interest in cross-jurisdictional sharing research and partnerships. It seems to me that may be one way to look at health departments. I don't know how we would operationalize it at present, but as we're looking at stratifying health departments and such partnership levels or the kinds of partnerships within the system itself, as we're looking at the way agencies are interacting with other partners within the systems, might be something useful to start thinking about in how we're segmenting those. Do you have any thoughts on that?
I would say that that's how the health department works with other, not health departments, but other, well, I'll say players, actors in the jurisdiction was part of the collaborations. And so some of that should be in the collaborations brief that's already out. but that was not specific health department to health department. That was health department with hospitals, clinics, schools, those kinds of partnerships.
And I think increasingly it's increasingly important to look at how the agencies interact with those other players in the system. So I'm glad to hear that. We also have a question from Catherine, and I think you sort of just answered it a little, but she wants to know if there's a report that is available to download. I know there were some things referenced on the dissemination slide, but do you have a full report available for download?
We do not. We've been so busy cleaning data, doing these presentations that we've not yet gotten to the point of manuscript. We worked really hard to get the NATO briefs done, so the one that we went out in October corresponded with that first webinar that we did, and the second brief will correspond to the second webinar, which will focus on the relationship between those services and the ACA. So reports are yet to, published, downloadable. Beyond the briefs, no. Pending, coming.
Keep us posted, and we'll make sure to get that out to our folks as soon as it hits.
Sure.
Are there other questions or thoughts or ideas about, particularly about those final few slides? I'm looking at them now. The issues of characterization within PHSSR, or the complexity of connecting organizational processes and outcomes, and something that I'm always interested in is the relationship of theory to PHSSR and to research design within PHSSR. Are there any? I know those are huge topics, but they're all, I think, of central interest to us as we're moving the field forward. So if anyone has any thoughts on those, I'd love to have a little bit of discussion about that. Anyone want to jump in?
Anna, this is Lisa in Colorado, and I think for me those were all very relevant and sticky, and I was nodding my head, and so I don't have any immediate thoughts to share, but I just wanted to share my appreciation for you bringing them forward today, so thanks for that in your presentation. But also, they are great things for us to be talking about more systematically, whether it's on these calls or in some other way, maybe not all at the same time, but I think we're all experiencing some of those things, and I would love to hear other people's thoughts in the future on some of these very specific PHSSR sort of research field-wide challenges.
Hey, this is Glenn May, just to jump in as well. I think there's also a host of very interesting, obviously, policy issues that are at play in this space as well, and I think some of these data start to bring into clarity some of these issues. And I'm thinking specifically when we think about the MCH bundle of activity, there are a number of policy mechanisms now that are historically and increasingly now under the Affordable Care Act that are supporting or potentially supporting these kinds of activities. Obviously, Medicaid has historically been a very important funding source for some of these activities, depending on state discretion and how they have decided to expand eligibility, as well as coverage for optional services for both moms and kids under Medicaid. The Title V block grant has been a very important source of support for this. Also, a lot of state discretion given this block grant and how those funds are used, and changes over time, and some important cuts more recently in the federal appropriation into the block grants there. But even more recently under the Affordable Care Act, there's been new MCH programs and activities funded through the Prevention Fund, and even part of the Innovation Center work at CMS has been dedicated to testing novel service delivery arrangements. And so there's a lot of ferment happening in this space. And again, I think there's certainly a need for additional analyses to start to carve out the individual and interactive effects of these different policies on service delivery and outcomes. I know that I see Dorothy on the line here as well. I know that Dorothy Salente from North Carolina has been thinking a lot about these issues as the head of an important national HRSA-funded MCH workforce center that she's heading up now, and that center is starting to grapple with some of these system integration issues. But I think all of us need to. This domain of public health activity, the MCH domain, is one where I think the system integration and policy effects are perhaps most active right now. So just to raise that issue and to perhaps stimulate thoughts across our PBRN enterprise about how to continue to work to disentangle some of those policy issues and again system integration issues.
That's a great point D on this slide.
This is Scott Frank. I would love to see, particularly with B, C, and D, specific presentations either at the PBRN grantee meeting or at the Keeneland conference with panels citing examples of these problems. And I think most of us could easily come up with examples, but those examples helping to lead a dialogue about addressing these issues, which I share an appreciation of you bringing them up in your presentation today, Michelle.
Oh, thank you very much. Thanks.
Very interesting that you raised that, Scott, because I had just made a note next to this slide on my notes that says possible breakout session at the PBRN meeting.
Yeah.
So we might find some way to spend some time around those questions, or
Yeah.
one or two of those questions as we can find time in the schedule, because obviously we have a lot of things we have to cover, but we are today, in fact, soliciting ideas for breakouts at the PBRN meeting. So
Okay.
I think that's a really important area that might merit some discussion. And Dorothy has also typed in, I'm wondering about point C and whether application of theories from other disciplines has much utility for PHSSR.
So this is Michelle, and I'm going to leap in with an exclamation star, you know, all those little whippy things. Yes. So one of my things is I also do a lot of work in organizational science, and I'm always astounded at how little of the organizational theory, whether it's organizational field set theories or it's organizational management theories, whatever, how little has come from organizational science into PHSSR. So I would really strongly encourage, if you're interested in looking at sort of these organizational processes and their effectiveness, maybe not, I don't know that I would have the ability at the moment to connect it to policy, but connect with your colleagues in schools of business who really sort of do strategy research, that do marketing research, that do any of those HR kinds of things, because there are so many theories that would be directly and immediately applicable, probably with some modifications, because most of those theories from organizational science tend to be developed for for-profit capitalistic environments, and so the extent to which those need to be modified for public administration, governmental agencies needs to be taken into account. But there are also plenty of public policy, public administration perspectives, theories that would also be applicable. So I imagine that in the discipline of public health services and systems research, that we could develop an interesting body of theories that are a blend from theories from organizational science, from public administration, from health policy, et cetera. So my answer to Dorothy is absolutely yes.
And
System
Dorothy is
science,
also, yeah, Dorothy has
but
also
system,
thrown out system science from engineering
but
as well.
system, yeah, that's a lot harder. I know it's really popular, um, but to actually apply those um, very constrained mathematical models from system science and engineering to very organic, um, ad hoc, humanly influenced processes is extremely difficult. And I'm not saying it's not a useful frame of reference, but in terms of a strict application, it's extremely hard to do that. In contrast to some meta theories from organizational science that really look at how organizations interact, how do they behave within sort of an organizational field. Um, that's those theories already exist. And you know, when you say system science, I include in that complexity science. That works at a within organization, but to apply complexity theory to interorganizational, I would have serious doubts that that's applicable. And I just
I
don't
would,
think
go
I
ahead.
just don't think the modeling, the mathematical modeling frame of reference that comes from engineering is going to be as useful as some of the models that exist um, from organizational science.
And I would throw in into the discussion too that there are many bodies of literature in communication science around partnerships,
True.
around implementation. There are also, I think, theories that we could look to from sociology or medical anthropology or other fields within the social sciences that I think could really be informing some of our PHSSR work. And I think it behooves us as a field to think very strategically and comprehensively about what we can borrow and adapt and apply from other areas. I think there's a lot out there. I couldn't agree more.
Mm-hmm.
This is Scott. I would add complexity science to the list of possible outside guidance on these issues.
And Glenn's being quiet, but I better throw in economics too if I want to keep my job, right?
Thank you, Hannah.
It looks like Gulzar is typing something, and it hasn't popped up on my screen just yet. So while we're waiting for that, are there any other questions for Michelle? All right, Gulzar's question is up. I have thought about the Agile model, Talcott Parsons, to inform how public health systems and LHDs have handled the budget cut. Does anyone have any budget cuts? Any thoughts on that? So that's another model of the Parsons
So
model.
this is Gulzar Shah. Hi, I've enjoyed the discussion so far. So as a sociologist, I've thought about AGIL, adaptation, goal attainment. There are four things that, or four reactions that systems can have. And at one point in time, I tried to use this in my discussion about the recession and its impact on health departments and public health systems. I would be interested in any thoughts about how folks think about trying to apply something that is a little bigger than a smaller level theory. It's more like a paradigm.
Mm-hmm. Mm-hmm.
So adaptation, goal attainment, integration, and latency being those functions that are needed for systems. And I thought that would be good discussion. I could never complete it, but that was a thought that I thought sociology can help in explaining, what's happening after the recession to the public health.
This is Michelle. I think if you were to combine that with, institutional theory in terms of legitimization and mimicking, I think you'd probably be onto something. But um, because of the way in which health departments are so they look at their neighbors a lot, and so I think that some of our systems theories would have to take into account what I'll just sort of at the moment generically call peer pressures.
This is a tremendous discussion, and I hate to cut it off because I think it's very exciting, and it's something we've had some discussions about here as well. The need to look at theory, the connections between theory and PHSSR and PBRN. So I'm going to have to ask us, though, to put a pin in it so we can get through the rest of our materials for today. But we will put this on the list of potential breakouts for the PBRN meeting, and maybe we can continue this discussion at the PBRN meeting. If not, if for some reason there are some more pressing issues that need to happen in those breakouts, or people aren't able to participate because they need to be in another breakout, we can perhaps schedule another call or another portion of a call to continue this discussion. I think it's really exciting, and I'm glad to hear people are interested in the area. But before we stop, though, are there any other questions for Michelle regarding her presentation of the maternal, child, and adolescent health programs and services resilience work today?
Well, I just want to say thank you for the opportunity to share, and I really appreciate everyone's comments and feedback. So it's been great. Thank you.
Thank you so much, Michelle. That was a great presentation, and obviously has sparked a lot of thought and discussion, and we look forward to continuing that very soon with folks. I do not have a presenter clicker, so I'm going to ask Lisette if she can move us forward to the other meeting agenda items, and just to go over a few things. First off, I'm not sure if we have anyone on the line or not, given that it's 7:30 in the morning there, but we are happy to announce and welcome our newest public health practice-based research network from Hawaii. And we have, as you know, added quite a few PBRNs in the last year or so, with Alabama and Pennsylvania and Hawaii now, and just several terrific PBRNs who are new to the group. We ask you to say hello to them. Many of them will be at the grantee meeting next month. Hawaii is being headed up by Jay Maddock at the University of Hawaii at Manoa. And they will be sending Tatine Sintel will be the representative who will be joining us at the grantee meeting. So let's all be sure to be very welcoming to all of our new PBRNs. In line with that, I know we're going to talk about directive in a few minutes, but I would also like to encourage some of the more established PBRNs who are working on their directive consortia for the applications for the directive opportunity to consider reaching out to some of the new PBRNs who are just starting out and maybe don't have as dense networks within our network of networks just yet, because obviously we'd like folks to be at the table for this, and there may be some shared areas of interest or shared geographical or shared governance issues that you could work together on as you're building your consortium. It never hurts to reach out and say hello. So if you don't have contact information for any of those folks, let us know, and we'll make sure that you get the contact information. Moving on down the list, PBRN research updates, the improved projects. We are working on those custom reports here at the coordinating center. Those should be done soon. Rachel Hogg is overseeing that direct effort right now. She's putting a lot of work into those, and I'm not sure if Rachel's on the line or not, but many of you, yes, she is. Many of you know Rachel, so I think that I just wanted to let you know that she successfully defended her dissertation last Friday, so I should probably say Dr. Rachel Hogg is working on those custom reports for us. So congratulations to Rachel again, and we're very happy to have her on our team, and we know that you guys are pleased to be working with her as well, so thanks, Rachel. In other news, moving from Improve to the DAX. The DAX projects, as you know, are underway. There is another virtual meeting on those next Monday, March the 18th. So those will be, or it was this Monday, sorry. The virtual meeting was this Monday, March the 18th. We heard reports from all of the DAX projects, and they all seem to be going along quite well. Many thanks to Dr. C.B. Mamerle for his leadership on that call and on these projects. Do any of the DAX or Improve centers, networks want to make any comments while we're on this PBRN research update section? Hearing none, we'll move ahead and talk a little bit about dissemination opportunities. Don't forget Frontiers and PHSSR. I think we're going to be moving to a monthly release calendar for this online open access rapid response journal. So it's going to get even more rapid in response. We're excited at the amount of submissions we've been receiving lately and the quality of submissions. So be sure to send in your emerging findings to Frontiers. And remember, we do have that new relationship with the American Journal of Public Health. Speaking of the American Journal of Public Health, as you all know, the call for papers for the AJPH special issue on PHSSR officially was closed earlier this month. However, we are happy to announce a slight extension or reopening or however you would like to call it, in that manuscripts are now going to be accepted through May the 15th. So if you would like to submit to the AJPH special issue, there's still a little bit of time to get that in. Again, through May the 15th. The information is up on the PHSSR website. Let us know if you can't find it. It's also going out again in the next newsletter, which should be coming out in the next few days. So keep an eye on the dissemination opportunities section of your newsletter as that comes out, because not only will you see AJPH, but any other calls that might have specific interest for our PBRNs and other PHSSR researchers. We try to make sure to put those within that newsletter. So please keep it up. But the AJPH submission, Michelle notes the AJPH submission is not available at the AJPH website. They did not set up a specific admission form. What you need to do when you submit to the AJPH special issue is include in your cover letter that this is for that special issue, and there are instructions for that on our website. I'll try to have someone track that down while we're going through the remainder of the call here and plug that URL into the chat box as soon as we can.
This is Bill Livingood. Just wanted to mention that when we first submitted and we ended up withdrawing ours to make some adjustments and resubmitted, it did, when we resubmitted, there was in the drop-down box for theme issues, there was this special issue now available. I still think it's a good idea to include it in your cover letter, but I think you can now indicate that in your submission process. It wasn't originally when it first opened, but I think it is available now.
Wonderful. Thank you, Bill. It's right there. Lizette has just posted the page with the information that is on our Coordinating Center website is now listed in the chat box. If you get there and you have any questions, please give us a call. Ann Kelly and Kara Richardson have been working very closely with AJPH on this issue, so we want to make sure that everyone has all the information that you need to get your papers submitted. And again, that new deadline is May the 15th. So we look forward to seeing your work in that AJPH submission process.
Hey, Ann, and I would just mention, for those of you, we know several of you, a number of our PBRN authors submitted by that original deadline, so you will be rewarded for that. You will, that first batch, all the manuscripts submitted by the March 10 deadline are going to get reviewed first and essentially first cut at making it into the issue. So so there are advantages to making that first deadline. Thanks to many of you who put the work in to make that happen.
Thanks, Glenn. Are there any other questions about the AJPH special issue? All right, moving on to funding opportunities, I think everyone on the line probably knows that the directive RFP is in the field right now. That is the dissemination and implementation research among PBRNs, and many of you were on the call, the informational call last week to talk a little bit about the funding opportunity and provide some specifics. Please remember that, and I know many of you have already contacted us, but the RFP calls for consortia of practice-based research networks of at least 2 PBRNs cooperating. We, because of the technical specifications of the RWJF submission system, we at the coordinating center need to know the makeup of your consortium before you start your specific proposal. And we need to know who's going to be the lead PBRN and the lead organization in that proposal submission process. So as I say, some of you have already contacted us. If you haven't already, please let us know. You can send it to the Public Health PBRN at uky.edu list or email address, and we would be happy to then enter that in our file so that we know as we're going through the submissions that everything is right. Lizette, do you have anything to add about that?
No, nothing else. I guess I have been getting a lot of questions about budgets, and I will be more than happy to talk to you individually. I can help you determine how your budget should be prepared. I answer questions about indirects and things like that. So just, continue sending me your questions, and I'll be happy to work with you.
Thanks, Lizette. Do we have any questions about directive that we can answer on the call? All right, Glenn has a couple of other funding.
So, hey, Anna.
Hello.
Sorry, this is Lisa. Can you hear me okay?
Go ahead.
Thanks. So I heard Glenn on the phone, so I don't have a question. I just have a request, Glenn, to use as much influence as you have. It is remarkably tough to put together a really quality proposal, even when you have everything aligned, that requires consortium, and even when you already have great partners. It's tough in the short time frames that we've been getting recently on these ones where a consortia or partnership across PBRNs is useful. And I think the more that we're all getting advanced and have advisory boards and others besides just sort of the couple of leaders in the organization that want to be involved in these kinds of decisions, the process takes a little longer. So any influence that you can have, Glenn, on helping Robert Johnson understand and extending the time for us to develop these, I think you're going to end up with a lot better proposals, and we're going to end up with a lot better work if we have just a smidge more time. That's my plea. I'm done now.
Thank you for that, Lisa. We definitely share your pain on that one, and yeah, point taken, and we'll continue to represent that issue. There's always a push and pull with this, and with the foundation in particular. They like to be as nimble as they can. But thank you for that, and we will absolutely do all that we can to communicate that, because we agree wholeheartedly with you on that one.
And I'm happy to articulate that better in some other formal place and maybe get some of my friends and colleagues on the phone to do that with me if it would be helpful to you. So it's not just your voice, but it's it's echoed by us. Whatever you need.
Oh, that's great. Thank you.
I will just reiterate, this is Scott Frank, that the dominoes across the different organizations, we just were able to present to our executive committee yesterday, and now our partners, proposed partners, have to present to their decision-making groups as well. So it is very hard to manage what are becoming less speedboats and more, we won't say aircraft carriers, but maybe at least cruise ships.
or at least armadas of speedboats, right?
Yeah.
All right.
Point taken. Thank you so much for that feedback.
And Glenn, I have a note from you on here that says you have a couple of other funding updates as well.
Yeah, just quickly on the topic, where beyond the directive, but just want to make sure that we've got there are some other relevant funding opportunities that are, especially in the federal space, to be aware of, and also well, one I want to make sure people had heard of is or were aware of is the new call that has been announced from our sister program at the Public Health Law Research Program. They have in the last week or two they've released their next announcement of PHLR funding for smaller scale awards, and so we've had several PBRNs in the past be successful in competing for PHLR projects. Lisa and her Colorado crew being one, and several others, and so that's worth taking a look at if you're interested in that. Visit the publichealthlawresearch.org website. Also, some other interesting federal funding opportunities that have come across our desk in the last few weeks. Several in the MCH arena. There's been a call from HRSA for several different calls actually for family planning research. One call released from HRSA that I think is funded under the Title 10 Research Authority. A second one that came out just last week, actually out from ASPE, the Assistant Secretary for Planning and Evaluation, again calling for research to look at the effects of the Affordable Care Act on family planning services and delivery systems. So for those of you who are doing work in the MCH space, those two calls might be especially of interest. And then continuing interesting projects coming out of NIH. One in particular that has caught our eye, and we want to make sure folks are aware of, is a new program announcement that came out of the National Institute for Nursing Research, framed around community partnerships to advance research. This is actually a suite of 3 different awards to fund different levels of research projects, from smaller scale projects up to R01 level, longer term, larger projects, all focused on community engaged research methodologies, including an interest in research networks and methodologies focused on prevention and population health, which fits right into obviously the PBRN and PHSR portfolio. So those and others will be profiled as usual in our next newsletter, but I wanted to give you a quick heads up.
Thanks, Glenn. Any questions about those items? All right. I think we can move on to the next slide then and just touch base a little bit about the annual PBRN grantee meeting, which is coming up in just a couple of weeks, believe it or not. I can't believe it's here again already. Here is your rough agenda. We have not assigned times yet, but we will be doing that in the next couple of days and getting this out to you very shortly in its entirety. We're going to be meeting from about 9 a.m. until 4 p.m. on April the 7th. I know a couple years ago, I think we started at 7:30 or 8, and our West Coasters were ready, I think, to flay us all. So we're going to try to be a little more considerate of you this year and get started about 9 o'clock. We'll have a state of the coordinating center and a state of the field sort of report at the beginning of the morning. And then Naima Wong, our project officer at the Robert Wood Johnson Foundation, is going to talk a little bit about the new strategic visioning that the Robert Wood Johnson Foundation has been doing, particularly around the culture of health, so that we can start thinking about how PBRNs and PHSs writ large sort of fit in with that culture of health and how we can support it and learn from each other in those areas. So we're excited about that discussion. We're going to have some discussion of the Improve work that has happened, and we'll have a little discussion about DACs so that everyone is sort of up to speed on both of those projects. Obviously, the Improve grants officially ended a couple months ago, but as we discussed earlier, those custom reports are being generated now, and some of the cross network analyses are underway. So we will we'll discuss where that stands, and then DACs are obviously in progress, and we'll have some things to talk about with those grantees as well. We're going to have a few breakout sessions in the afternoon, as we usually do. We're among the items that have been proposed are the FAST 2.0, where FAST is going at University of Washington with their partners across the networks, and a little discussion around data collection and those kinds of issues. And we're looking for other suggestions and ideas for those breakout sessions. I think obviously we had some nice discussion around building theory for the field, for the PHSSR field, and for PBRN practice. So so I think that's a potential area for a breakout study or for a breakout session. If anyone has other suggestions for breakout sessions, we'd love to hear them. We typically do 3 or 4 simultaneously in the afternoon of the PBRN grantee meeting. So feel free to type them in the chat box, or I'll be quiet here for a second and let anyone jump in with a topic idea. The floor is open if you have some breakout session thoughts.
Anna?
Mm-hmm.
This is
Yes.
Sarah from Colorado. How are you?
Hi, Sarah. How are you?
Fine. So one of the things that we had talked about, and with the Improve group, was possibly doing something related to Improve and issues with data collection or data. I don't know exactly how to put it, but we had talked about submitting an abstract to Keeneland and forewent that to possibly have some kind of discussion at PBRN meeting.
Mm-hmm.
Could that be a potential topic?
That is a potential topic, and that should have probably been in the bullet points after Naima's Culture of Health and before the panel discussion of DACs.
Okay.
But it's just not there. I don't know that that's going to be a breakout session, although that conversation might evolve and inform some of that FAST breakout session. But I think that we want to dedicate some time, some plenary time to that in the morning. That's my understanding of the plan. Is that what you were thinking?
Yeah, I just wanted to throw it out there as something we had talked about before. So
Absolutely.
sounds good to me.
Absolutely. Because I do think that improved discussion is going to flow nicely into the FAST breakout session as well. But thanks for bringing that up, Sarah.
Yeah.
Any other thoughts on potential breakout sessions? Well, this is not a speak now or forever hold your peace moment. By all means, if something comes up to you in the next couple of days before we have the agenda set in stone and sent out, please, by all means, email us. You can email me or Lisette, or just the Public Health PBRN at UKY account, which is probably the best way to make sure that we get it. We would love to have that, your suggestions, and so that we can finish formulating the afternoon portion of the program. I'm excited to talk about a few things on the Tuesday morning all grantees session. As you know, in the past we have convened with the NNPHI and National Coordinating Center for PHSSR grantees, and this year we're going to do the same, whether it's formerly known as junior investigators, now known as pre- and postdoctoral researchers, mentored research scientists, or the PHSSR grantees through the NNPHI program. We're going to have an opportunity for everyone to come together, and we're combining some workshop activities with some networking opportunities, and we're excited to see how this goes this year. We're starting out by asking those who would like to bring posters highlighting their work, whether it's a specific grant you're on, or if you're a PBRN, perhaps the way, and you're not currently funded, the way your PBRN is structured, or engages your partners, whatever that may be. We're inviting everyone to bring a poster about your work, your efforts within the PHSSR space. And we will have poster boards set up in that grantee meeting room. If you are planning to bring a poster, and you should have been contacted already. If for some reason your PBRN has not been contacted, let us know. But I think the emails went out a couple weeks ago. So if you're planning to bring one, please make sure to send us the title and the author by March 24th so that we can make sure we have adequate poster space for those. We're going to have some dedicated time for people to walk around, look at the posters, connect, talk about potential opportunities for collaboration, potential synergies of research interest. So we definitely encourage you all to participate in that. If you have the time and the means to put together a poster in the next couple of weeks, it's a great opportunity. And we also are, I think Paul Irwin's on the line. We've got some very exciting workshop activities planned starting around 9:30 around some of the major challenges of dissemination. And Paul, would you like to say a word or two about that, prime the pump a little, or can you chime in? Are you on the phone? Paul may just be listening in on the computer. So I will go ahead and let you know that we are planning to break into some small groups for discussions of some very focused discussions around specific dissemination challenges that have been addressed in the literature and brainstorm across grantee populations. So we want PBRNs to be interacting with junior investigators, admitted research scientists, and all kinds of folks to brainstorm different solutions to some of the major challenges identified in the literature. And we're excited about that work. To that end, however, we're going to be sending out an email to all of the grantees in the next couple days, probably Monday or Tuesday of next week. So we'll have a link to a very quick questionnaire. I think it's a 4-question questionnaire. One of them is your name, so it's that simple. Your name, your funding mechanism, and and asking you to select 3 of the dissemination mistakes that most interest you. So we do ask those of you who are planning to attend the meeting to please return that promptly. That's going to help us a lot in planning the logistics for the flow of that workshop. Are there any questions about that? Okay. We want to thank you for making your travel arrangements. I know in prior years we have been able to, on a first-come, first-served basis, sometimes offer an extra night's accommodation paid for through the coordinating center, but unfortunately the price of airfares are so high this year that we cannot offer an additional night to the grantees. In past years the airfare has come in under budget, allowing us a little bit of wiggle room, but this year we have maxed out that budget, so we cannot unfortunately take any requests for a second night of lodging. Obviously, we hope you can stay, and we've helped you make your airfare arrangements. And if you are staying that extra night, unfortunately, that will need to be on your own dime. And Lizette and Nicole can help you work through those issues, through the technical issues related to that. Are there any questions about that before we move on to the next slide? All right. Thank you. Moving on, thanks again to all of you who have submitted 2014 social network analysis rosters, your membership rosters, so that we can field the social network analysis survey again in the next few weeks. A few of you have not gotten back to us on that, but I just want to remind folks that that is a requirement. We need to have those in hand if you are planning to apply for one of the directive for the directive funding mechanism. So if you have not yet gotten us your updated network roster, we need to have those in hand as soon as we can get them, and certainly before the current April 2nd deadline for directive submissions. So please be getting those to us. And again, thanks to those of you who have already gotten us your updated network rosters. We also have a few resources here. These are some articles and publications that have come out recently. A few of them are focused on clinical PBRNs and some of the long-term analyses that have been ongoing of clinical PBRNs and how they maintain engagement, high engagement levels, and how they are leveraged for dissemination, those kinds of issues. And we thought that those might be of interest to the public health PBRNs as well. Obviously, clinical PBRNs have been around a little longer than we have as a field, so where we can learn from their efforts and figure out what transfers and what doesn't to our world is obviously going to be helpful. There are also a couple of IOM discussion papers that have recently come out. One of them is Glenn's. So you might find those of interest. We encourage you to have a look at them. And then the practical playbook for collaboration between primary care and public health has recently come out. I know a lot of folks have been interested and waiting for that publication, and it is out there now. It is, I believe, the Beaumont and CDC and trying to remember, the Beaumont and CDC, I think Duke University, all collaborated very closely on that. Obviously, the relationship between primary care and public health is of key interest as the system continues transforming, and as we're trying to capture those pieces of system transformation, that can be a very valuable handbook just to look at. There are a lot of interesting best practices sorts of approaches are derived from cases and individual experiences. So I think that's worth having a look at for many of you. Are there any questions? Oh, and one other thing. Remember that to always check the resources section of the new combined center newsletter, because we try to link out to as many of these kinds of resources, recent publications that may be of interest, white papers, gray lit, anything that has come out recently that we think might be of interest to you. Please keep an eye on that resources button and resources tab in your newsletters. Any questions about this section? All right, as you can see, we have here the presentation schedule for the next, for the rest of the year, really. We have New York coming up in May. Remember that there will not be an April call because we do have the PBRN grantee meeting in April, so we won't be having a call. But in May, New York, followed by California, Connecticut, Ohio, Colorado, New Jersey, Washington, and New Hampshire. If you see your PBRN on there and suddenly realize that, look, there's a conflict, I'm out of town, or our researcher is on sabbatical, our lead researcher is on sabbatical, or whatever it may be, our lead practitioner is on vacation, whatever that may be, try to work with one of the other networks to change dates, to trade dates, as it were, and just make sure that we're in the loop so that we know who we need to be communicating with in that month. All right, we have just a few minutes left correction, August is Colorado, Lizette says. She's typing in the bottom box, and then September is Ohio. So Colorado and Ohio are flipped on your presentation schedule. But if anyone has any other conflicts or issues, please feel free to work with the other PBRNs to find something that works. And if that's a big problem, and you're just not having any luck, give us a call, and we'll try to work with you and see what we can do. That gives us just a few minutes for other questions or issues or highlights or items that people want to bring up. So I'm going to open the floor now. Are there any burning issues folks want to address? All right, I hear none, and no one seems to be typing in the chat box. So with that, you just found 5 minutes in your day. Congratulations. Make good use of it. If you're somewhere where you can get a little sun, do. I hope everyone has enjoyed the call. We want to thank again Michelle Issel and the North Carolina PBRN for leading the research in progress portion of today's call. It was really interesting. And we look forward to seeing everyone in a few weeks in Lexington. And for those of you who aren't traveling, we are going to try to have an Adobe Connect set up so that you can at least dial into as many portions of the meeting as you can attend. We'll be following up with details about that soon. That said, everyone, thank you so much and have a great Thursday.
Bye-bye. Thank you again.
Thank you.